It's a pleasure now to introduce our first speakers from the Cuyahoga County Community Health Improvement Plan, which is some remarkable work in this space in a very broad way. And we're privileged to have two speakers, Martha Halko, who's the Deputy Director for Prevention and Wellness from the Cuyahoga County Board of Health, and Gregory Brown, who's the Executive Director for PolicyBridge. Who's going first? Martha? Oh, you're both? Okay.
Well, good morning. Well, that was kind of weak. Good morning.
Good morning.
All right, we're all alive here today. It is our pleasure, Martha and mine, to be here with you today to speak about our work in Cuyahoga County. We're excited about this work because we think this work could not only be illustrative for the kind of work we're trying to do to solve health inequities, but we think this can be bedrock work that can help us to transition into those other areas that we refer to as social determinants. Because what we understand is the intersectionality of all of this work must be understood so that we can have great impact and reduce health inequities. I think this is the roadmap that we are using to help us as we journey through our work. And the Cuyahoga County Community Health Improvement Plan came out of a process that was launched in 2009 by the Cuyahoga County Board of Health and two other health departments, one being the Shaker Heights Health Department, the other one being the City of Cleveland Health Department. And they wanted to really work together to try to develop a comprehensive approach to how we solve the issues that were being described through data that was being used and collected, both quantitative and qualitative. So one might ask the question, why a community health improvement plan? And we think that, first of all, in Cuyahoga County, multi-sector commitments to improving the health and quality of life for those who live, learn, work, and play in Cuyahoga County was very important. The second thing we needed to do was to really address local inequities and disparities. So to do that, what we understood was there was really no current comprehensive plan in place in Cuyahoga County, and that the lack of a plan has limited the county's ability to align partnerships, expertise, data, and resources around key issues impacting health and well-being. Therefore, we thought this was an interesting and also effective way of organizing ourselves to deal with that. And the last point, which is a very important and consequential point, was that each one of these organizations and health departments needed to engage in an accreditation process, and this also fulfilled that aspect of their work. I want to spend a minute on this slide because I think to understand what's different about our work in Cuyahoga County, one must understand what we think is our aspiration around what we would like to see when all of this work is accomplished and we can actually start to see improvement. And it basically says that we believe that all people in Cuyahoga County have the right to live their healthiest lives, no matter where they live or work, how much money they make, or what their race, religion, sexual orientation, or political beliefs may be. We started with that because what we understand is if we really want to have equitable outcomes, we must work together to ensure that these things happen, and they must happen in strategic and really planful ways. So this is our context for getting started. So we have a state of health here. And if you think about the state of health in Cuyahoga County, these data points kind of help you understand some things that we found out as a result of looking at data. First of all, we rank in the bottom third of all counties in the state of Ohio when it comes to residents' health outcomes. Secondly, we're in the top 10 in the state in terms of clinical care, but this has not made a difference for our residents in terms of their health outcomes. So what we understand is the conditions that shape health are not spread equitably throughout our county, and that there is a significant difference in life expectancy depending on where someone lives. The map you see in front of you looks at the causes of death in the United States in 2000. And in 2011, a study published in the American Journal of Public Health shows what can be described as the actual causes of death. What you see in the columns to the left are the traditional leading causes of death, accounting for approximately 75% of all deaths. In the middle column, you see the impact of factors that are attributed to 45 to 50% of all deaths. The last column is where you see socioeconomic factors that can be attributed to 35% of all deaths. So, when looking at this map, or excuse me, this graph, one could say on the left, we have medicine. In the middle column, we have traditional public health. And in the last column, we have our new public health philosophy and model around population improvement. What you're looking at is a life expectancy map in Cuyahoga County by neighborhoods and municipalities during the period 2008 to 2010. What's interesting about the map is you can see the core city of Cleveland, which is kind of encircled in the dark circle, is where you have the likelihood for the least amount of life expectancy. That also extends to our first ring suburbs, which are connected to the core city of Cleveland. And just so we know, there is a white spot in the middle of the map, if everybody can see it. That is because due to the level of population and the fact that it's a mostly industrial area, when we looked at the data, we could not use it as a basis for the model that we put together. I want you to look at these two maps for a moment before I speak. So the first map is once again between the years 2008 and 2010, 2006 and 2010, the poverty rate in Cuyahoga County, especially the significance of poverty in the core city of Cleveland, Ohio. And then let's look to the next map, which is the percentage of African American population 2010 in Cuyahoga County. And we look at it, it is mainly on the eastern border and core city of the city of Cleveland. If you look at the first map, this map on poverty, and the map on African American population, you start to see that there's an association between where people live, race, and the lack of life expectancy. This is an infographic that we developed to put in our chip. And we wanted to do this because we wanted to illustrate several data points and also to try to drive people to understand that there's a conclusion that evolves out of this as it relates to life expectancy. And at the top you can see unequal opportunities, and we have several data points as it relates to African American and Latino Americans. In the second column, we have poor health, and we have data points as it relates to, once again, those populations. And then in the last column, we talk about those two factors, unequal opportunities and poor health, do equate to shorter lives. And we talk about the fact that African American babies are 3 times as likely to die than white babies. And we also talk about the difference in lifespan being up to 20 years in difference, given where you live in Cuyahoga County versus many of the outer ring suburbs. So that's the problem. That's what we're really trying to solve. But one of the things we've learned is it's nice to talk about the problem, but why does it matter? What is the value proposition that evolves as it relates to this problem? And it matters for us because in Cuyahoga County, people of color are needlessly suffering and dying before their time. The other part of our value proposition is that we all pay for poor health. The Joint Center for Political and Economic Studies Health Policy Institute in 2009 came up with a figure of greater than $1 trillion that we have in combined costs of health inequities in the United States. That's a substantial figure, and we all pay the cost for that. This next illustration is one that I always like to use because when you think about equality and equity, many times people think they're synonymous, and they use them interchangeably. They are not synonymous, and they should not be used interchangeably because they actually mean different things. The illustration on the right is one of equality. If you look at the picture, kids outside of the ball yard are trying to see the game. And we want to give them all an equal opportunity to see the game. So we stand them on equally sized boxes. You see in that picture that even when we give them the opportunity that's equal, each of the children is not able to take advantage of the opportunity. When you move to the equity side, you still want to provide the opportunity to see the game, but you do it based on factors that are physical, social, emotional, and others. Hence being the shorter young guy needs a couple of boxes to stand on, and the taller guy can still see the game without any boxes at all. That's what equity is about. As one of my colleagues has told me, her illustration to her students is all kids in a school getting tennis shoes is equality. Those same children, all of them, getting the right sized shoe is equity. So we've started to build a case for equity, and that case really emerged from the unacceptable differences in life expectancy, catalyzed our efforts to gain a deeper understanding of how place and race impact opportunity and health. We committed early on in our process to address both traditional public health and complex social problems. And we knew that we needed to work together to do that. We needed to work not only across sectors, but in multiple sectors at the same time, holding multiple perspectives about our work. We also were lucky enough to be part of a national program called Place Matters, which is now changed its name from Place Matters to Collaboratives for Health Equity. Our local Place Matters team was very instrumental in working in this process, and they still are involved. I'm part of that team. We have team members that are part of the HIP-C partnership at all levels, whether they're in the backbone, which is Martha. We have steering committee members such as myself. We have members in the consortium, and we also have members on all subcommittees. So we brought the equity perspective in, and we've been able to engage members of our partnership in a way to help them understand why we need to have shared values and commitment to equity. Why we need to think not only with our head, but with our heart if we really want to accomplish what we want to do. We must also recognize the historical policies and practices have shaped our current inequities. We also realize we must build collective capacity. It is great if we have programmatic approaches that demonstrate that we are making progress. But we really think the collective impact and collective process is the only way to have long-term sustainable impact on these kind of inequities. And last, we wanted to think, understand, and value differently so that we could act differently. And we call that perspective transformation. And it's interesting because we spend a lot of time talking about diversity, equity, inclusion leading to equity, but you can't get to any of those things unless you go through a process of thinking, understanding, and then creating values that are different from those you currently hold. Once again, it doesn't mean you dismiss what you have. It means you learn to hold multiple perspectives so that you can then act differently.
Thank you, Greg. We're going to tag team here a little bit. So thank you for that foundation, Greg. Really what Greg has talked about is really the foundation for our entire process. We've followed a familiar process that many of you may be aware of for a health improvement planning process. It's a model program, model process, the mobilizing for action through planning and partnership. So we followed that traditional approach, but with the flexibility and intention on focusing on equity through the process. So our process certainly took maybe longer than most, but there was much intentionality to maintain that equity frame throughout. So we moved through the 6 steps of the MAP process: organizing, visioning, assessments. We completed 4 assessments. We went through identifying strategic issues and key priorities, formulating goals and strategies, and we're currently now in the action phase of our process. So we committed early on to what we call an evolutionary process, allowing ourselves to learn from our process, and the willingness to slow down when we needed to readjust or redirect ourselves, in essence, really to maintain the frame for equity that we had committed to. So this is an overview of our timeline. Again, probably not a traditional timeline. We worked really over the course of 5 years with the recent release of our health improvement plan. But there was a lot of considerations. We probably spent the bulk of our time in the data collection, both qualitative and quantitative data collection. And during that time frame, we actually had very limited resources and limited capacity, so that time took longer to move through those processes. And then we were actually able to secure some funding moving through the facilitated selection of strategic issues and priorities through the release of the Community Health Improvement Plan. So that was a really important part of our process. For us, as Greg mentioned, our partnership is really our foundation. We've committed very intentionally to bringing diverse sectors and diverse disciplines around the table from the earliest parts of our planning process. So we've also changed our structure through the process. So very early on, we were a smaller group of about 50 active individuals and organizations. And we actually kept that group smaller in order for us to have a productive planning process. We're very committed to building trusting and strong relationships. We definitely learned to work in new ways, bridging our interests, bridging our values, bridging our capacities, leveraging capacity from the organizations that were part of the process. But we did start to build a network connected of organizations and individuals that we began to communicate with. So we had a network of over 200 partners and organizations that were basically part of a listserv and following along in our process. And over time, currently we have over 100 active organizations. That's organizations alone. So there are many, many individuals involved in our process currently, and over 600 in our network. The important part of this process has been, for us, what we call building a movement. We're continually looking to align interest, align values, align capacity, align resources to grow the movement. The greater the alignment, the more impactful we can be in impacting the population health in our region, and in effect being impactful on the priorities that we've selected. I will say this has been both a challenge and an opportunity, as Greg has talked about. When you've got a network of this size, you understand that you have organizations at varying levels of readiness throughout. People come to enjoy the network, and others leave the network, and to maintain that base value and that base understanding, we were really intentional about trying to build capacity and knowledge throughout this process. So that's a very time-consuming commitment, but really worthwhile in our view. So as we moved through our process, the visioning phase was a really foundational phase. We moved through a visioning process with our partnership, with a very strong commitment to a set of values and beliefs, as Greg had mentioned early on. And being that we were fairly heavy in the healthcare and public health sectors in the partnership, this is a new narrative for public health, this conversation around social determinants of health and focusing on issues at the root of poor health outcomes. And even more so, beginning a conversation around racial inclusion. So this was definitely a new conversation, but I feel that very worthwhile. And while we didn't have all participants fully on board, there was a generalized commitment to move in that direction. And so we committed early on to have a vision and values that reflected what we would like to accomplish in the community. So our vision has remained consistent throughout our process. And it really reflects our beliefs and our commitment to providing opportunities for everybody in our county to be healthy. Our mission, on the other hand, has actually changed. And this is the type of flexibility that we're committed to having. I would say our original mission was very public health speak, talking about assessments and data, and that was the how-to that we described early on, but we really recognized that mission, as we moved into action and were committed to sustaining our partnership and consortium, did not really advance our vision. So we took the time through group process to craft a new mission that we felt reflected the direction that we were moving and supported our vision. So we have one core value, and I will say that many have asked, why just one? We in public health are very comfortable in other organizations with having multiple core values, but we feel this one particular core value around opportunity speaks to us the broadest. This core value was selected with the understanding that opportunities form the foundation for health. Our goal is to really provide opportunities for everyone to achieve their fullest health potential, whether that be opportunity for access to healthy food, opportunities for safe and affordable housing, opportunities for transportation, physical activity, all those social determinants of health. That is so foundational to the production of health that we feel that is the core value that, in essence, guides our work and has been instrumental in shaping the strategies that we've selected moving forward. So just a closer look at a couple of the assessments. We did what one would call a traditional community health status assessment as part of the MAP process, one of the 4 assessments. But I will say from the inception, we looked at that data differently. We were very intentional about looking at that data through an equity lens and understanding the opportunity differences and differences in health outcomes by race, ethnicity, and place. You had seen the maps that Greg had shared, and the results of the community health status assessment were very supportive of seeing that the poorest health outcomes were in our urban core, the city of Cleveland, and the inner ring suburbs. The other assessments that we invested a lot of time and energy into were the qualitative data collection, the community themes and strengths assessment. And at that stage in our process, we actually had work groups for each of these. There was a collection of partners and organizations working to move through the community health status assessment, and another group that convened around the community themes and strengths assessment. And as I described later, our structure has actually changed, and many of these groups are still convening, but under a different name. And I'll touch on that. But for the quality themes and strengths assessment, we completed a quality of life survey. In essence, we asked our residents, what are the strengths, what are the needed improvements and health issues in your community? And we worked with Case Western Reserve University to disseminate that survey over the course of 4 to 6 months, and over 5,500 respondents in our county provided feedback through that survey. We actually oversampled the city of Cleveland and the inner ring suburbs to assure that we had representation, strong representation from those areas of the community. And that was important information that was considered as we move forward for the selection of our strategies and priorities. We also completed a youth photo voice project because our survey we only had 18 years and older respond to the survey, so it was an adult survey. And we really wanted to assure that we had community voice from the youth in our communities. So we identified several groups, boys and girls clubs and other types of groups of youth who actually took part in a youth photo voice project. And we conducted key stakeholder interviews that were all part of our qualitative data collection. And I really like to share these images because at times the images are so much more powerful than some of the data that we actually collect from our health status assessment or other sources. But the picture on the right is from a young person from the Boys and Girls Club. And basically the comment that they provided to the photograph they gave is to show people that you will find love no matter what the color. And the one on the left is actually a group in one of our inner ring suburbs where they actually had done away with most of the basketball hoops. And so the young person basically in sticky notes put, "Where have all the hoops gone?" Just expressing the challenges and understanding that there are differences in interests based on race and color, and we have to be conscious of what opportunities we provide to our youth in their communities. And there was a strong desire to have basketball available. So as we move through all the assessments and all the qualitative assessments we did, we really started to move in then to the strategic process of identifying issues and priorities. This was a challenging process as we brought together a lot of interests and different differences in interests and various priorities, but we went through this process effectively. We went through ranking and selection of criteria, prioritization of issues, and in fact, we somewhat organically aligned with the National Prevention Strategy as well as the State Health Improvement Plan. There wasn't sort of an intentionality to make sure that everything we select aligns, but it so happened that we referenced those plans and saw quite a bit of alignment. So in our first iteration of considering the data and formulating strategic issues and priorities, we actually generated 14 priorities that range really across the spectrum from complex social issues to more traditional public health issues or healthcare issues. You see infant mortality, tobacco use and prevention, mental health. Mental health was actually generated by our community. It was one of the top health issues in our quality of life survey. In-school and out-of-school supports, That was actually generated as an improvement needed, more opportunities for youth in the community. Quality of life for older adults, violence reduction, health and land use, natural environment. These are all really, really important issues in our process, but we needed to take the time, recognizing that we did not have the capacity and resources to move 14 priorities forward. And as you can imagine, there was a lot of interest and support for each of these priorities as we moved through the process, and we needed to really determine how would we choose our top 4 priorities. So we actually reconvened and really started to look at that data some more. We established additional criteria for prioritization, but probably most importantly, we wanted to remember the equity lens and the equity frame that we established in the selection of the top priorities. We did not want to see only traditional public health or healthcare issues trickle to the top. We've seen many plans across the country, and it becomes sort of easy and comfortable to default back to very traditional public health issues. And we did not want to see that happen. This was a really pivotal point because at this stage we recognized we were going to be collectively working on these priorities for up to 5 years. As you move through the MAP process, that's in essence the timeline for reassessment. So at this stage, this was one of our retooling moments. We really needed at this time to bring in some additional support. Most of this work is coordinated day to day by the health department, a team of wonderful folks that I work with, and then our core planning partners at this stage, which in essence were generously providing in-kind support through this process. So we really felt like we needed, as the consortium grew, some reinforcement and really strengthening the equity foundation. So we engaged Common Health Action, a public health organization from here in DC, and we actually had experience from them in the past through Place Matters, through our experience with the National Collaborative for Health Equity. And so we knew of their ability to provide that support, that equity grounding and equity foundation. So they actually worked with us to, we convened our group and they worked with us to prioritize those 14 issues down to 4. And that was through a grounding in equity. There was focused time on really talking through what do each of these priorities mean through an equity lens, who benefits, who's burdened, and really working through an understanding of what do these priorities mean for us. In addition, I'll talk a little bit about this further along, but we actually held a health and equity workshop which preceded the selection of the goals. So these are our current areas of focus. Since these priorities were selected, the consortium has started to divide up and rally around each of these priorities. And as we worked on developing goals and strategies, there was sort of the natural development of subcommittees around each of these priority areas. Really, the subcommittees have been meeting for several years now. And these are the current names of the subcommittees. The subcommittees themselves have changed. The Increasing Nutrition and Physical Activity Subcommittee was renamed to Healthy Eating and Active Living. And Eliminating Structural Racism as a Social Determinant of Health was very long, so they just reduced it to Eliminating Structural Racism. So this was the other pivotal phase in our process. Basically, we wanted to determine what do we want to achieve and how do we want to achieve it. So for each of these phases in our process, we convened our whole planning group and consortium for a facilitated process. Prior to the selection of goals, we actually went back to the community and asked the community what should be done to address the priority issue. We wanted to understand what the community's feedback was on these priorities and how they thought we should address these issues. In hindsight, we wish we could have reached a lot more people than we did. Reaching out to the community consistently is a capacity and resource intensive process. And that's a recommendation that comes out of our process, is the intentionality of knowing that that is the case and being able to build that capacity and resource into your process to assure that you can continue to fruitfully and meaningfully connect with the community. But we did go out and hear from about 60 community members and received their feedback. We connected with our partners through an environmental scan. This is because we wanted to begin to really understand, as our consortium grew, how do our partners' missions, values, and interests align with the direction that we're going with, the priorities that we've selected. And then again, we completed the health and equity workshop, which I'm going to talk a little bit more about. This was facilitated for us by Common Health Action, and it was actually a required workshop for those who would then be convening the day before or the day after to establish the goals, to articulate the goals and begin to develop strategies. Again, as we've moved through the process, our partnership and consortium had grown, so there were new participants, new members who were excited about the progress. And when you're starting to describe how you're going to address this priority, you really want to have an even playing field with folks in relation to understanding and equity grounding. So this was a really critical workshop for us. Basically, the purpose of this workshop was to create a common language, a common understanding. There was a review of the whole historical perspective of how historical practices and policies have influenced current inequities. There was interactive opportunity to do various exercises. There was the privilege and oppression walk that Common Health Action facilitates. There was various opportunities to be interactive. And I just share some of the feedback that we received from those participants. Every time we have a convening, we do a very thorough evaluation. And this spoke volumes. It really resonated with those that participated, and as Greg mentioned earlier, I think we really achieved some perspective transformation by those that really talked about how their views were changed, which was an important piece that we needed leading into the development of goals and strategies. We do also consider the evidence very heavily. Our strategies that are part of our current priority areas are evidence-based strategies. But not all of them. We are also open to innovation and looking at emerging best practices. Greg will be talking about the eliminating structural racism work, and the evidence is not as fruitful in that area, so we are needing to be open to innovation, and that was a commitment we had early in our process. But this visual just really depicts that for us, the evidence is in the context of community input and all the other steps that we took through this process. It's not the only driver for this process.
Well, thank you. Yeah, we're switching off. And that's because I wanted to spend a little time talking about this slide in particular. Martha has mentioned several times about the process and how it evolved over time. And what were some of the interventions or activities that helped shape our transformation, helped to develop our understanding, help us develop a common language and a shared process of meaning and understanding about the work. One of those was the creation and development of this report called History Matters, which came out last year but has been worked on for since 2013. And it really is understanding the role of policy, race, and real estate in today's geography of health, equity, and opportunity in Cuyahoga County. And it was a policy brief prepared for, at that time, what was called the Cuyahoga County Place Matters team. We changed our names, so as did the overarching program change its name to Collaboratives for Health Equity. We are now calling ourselves the Achieving Health Equity Initiative. This report was prepared by the Kirwan Institute for the Study of Race and Ethnicity and the City and Regional Planning Program at the Knowlton School of Architecture at The Ohio State University. And what was interesting and what was really, really phenomenal about this report was that we were able to go back and look at how policies at the federal, state, and local level really created a lot of the inequities that you see today, especially as it relates to race and to place. If we were to go back to the maps that I showed you earlier about life expectancy and poverty and African American population and where they're located, you'll see in a map in a minute how all of those are juxtapositioned by what was a preceding map that was created early on. And what we're trying to do here is really talk about something a little bit different. Most of the time we talk about the impact of inequities or health disparities from an individual perspective. What does the individual need to do? How do they need to change? What should they do so that they're living a more healthy life? We understand that, and we think that's very important, but we understand that to be only part of an equation. What we also know is that if we do not look at the structures and systems in our institutions and start to understand how to create more equitable organizations and institutions that end up aligning with systems and structures, we will not achieve equity in this country. We won't be able to do it. Dr. Harry S. Green, who is a systems change theorist at the University of Chicago, has a systems change theory that says every system is exquisitely designed to produce the result it gets. So, yes, every system is exquisitely designed to produce the result it gets. Okay? Sit with that for a minute. It's not a life-altering thought process, really, if you think about it for a moment. We get what we sometimes act as if we don't know what we're doing, and it's not intentional. It could very well be unintentional, but the designs we use are very intentional because they're steeped in our disciplines, they're steeped in our traditions, they're steeped in our culture. So unless we're able to go back and understand what led to these things, we won't ever be able to get out of that mode of thinking and design better systems that are more equitable, leading to more improved outcomes. This is a map from 1940. And I want to talk about this issue of redlining. Redlining is a term associated with the way banks use to grade and map out different geographical areas to determine how much federal banking a loan would receive. The United States Congress created the Homeowners Loan Corporation, HOLC, in June of 1933. The purpose of the corporation was to refinance mortgages that were in default. That was in order to prevent foreclosures. In 1935, the Federal Home Loan Bank Board asked the HOLC to look at 239 cities to create residential security maps to indicate various levels of security for real estate investment. The red areas received no backing, and the yellow area received 15% backing. Members of these areas were essentially cut off from receiving any federal funds. Now, this is a policy that was a national policy. And if we go back, that's the city of Cleveland. If you go back and look at the map of the city of Cleveland today and just to position this map over it, it has a history that goes back even farther than this is 1940. We actually, through the History Matters report, were able to uncover policies in the Library of Congress that go back to the early 1900s. I'm talking about 1905, 1907, that talk about race mixing and how they were going to use real estate to delineate racial place-based barriers. So when you think about this, all of this stuff is interconnected, and it has impact on people today, even though it happened many years ago. So now we get to the Eliminating Structural Racism subcommittee, and as Martha said, it really is a much longer name. We decided to cut the name because people really wanted to get at the eliminating structural racism aspect of this. Once again, I ask you to take note of structural racism. We're talking about structural and institutional racism. When we talk about this, we are not talking about individual racism. And so we talk about this in terms of the impact of systems, structures, and institutions on people. A little different perspective of understanding and a different mode of thinking about designing solutions to problems. I am one of the co-anchors. We also have co-anchors from the Cleveland Neighborhood Progress Organization, which is an intermediary organization of community development corporations throughout the city of Cleveland. And so my colleagues and I work very diligently with a number of consortium members to really try to address what the subcommittee really needs to do to, first of all, evolve a process within our own consortium where we have shared meaning and shared understanding, common language, and a perspective that is transformed from what we think traditionally to what we need to do to be more equitable. Secondarily, we know that this is an evolutionary process. It's iterative. So as much as we learn, then we're able to integrate that into what we know. But we also know that it is a process. It will take time. It is not something that we can put a stake in the ground and say by 2019, all people in Cuyahoga County will have a more equitable system, because we can't say that about our consortium right now. What is important is that we're trying to teach organizations how to recognize and address structural racism. We're also encouraging organizations to work closely with community members. That's something that has not been a tradition in not only the city of Cleveland, but Cuyahoga County. In fact, we've had severe fragmentation to the extent that in many cases, institutions, organizations, and structures such as HIP Cuyahoga are looked at as the enemy when we come in to work with community. We're also developing policies to create social and economic opportunities for all people. One of the things that we're working on right now in this subcommittee is the development of a readiness assessment that will be first given to members of the consortium. It will test and be able to give us some quantitative data about whether people are in a position of leading, following, or supporting when it comes to equity within themselves and the way that they view the world. That's the first step. Our next step would then be to move from that data, understanding that data, and developing recommendations for how we move forward, to then think about how do we engage our member organizations around this same issue. What we already know, working with Common Health Action as a consultant, is that you've got to segment the work so that you can understand specifically the population that you're getting to.
Thanks, Greg. So just as a brief overview, I'm going to go through the other priority areas just to give you a sense of what our other subcommittees are working on. And at the bottom of each slide, those are anchor organizations that, in essence, as Greg has described, guide the work of that subcommittee. So for linking clinical and public health, it's focused on bringing the healthcare system and the public health system together around shared priorities and vision. Healthcare systems are involved in our partnership and are involved in this particular subcommittee. One of their focus areas is actually looking at working together for the completion of a combined health assessment Health departments are required to do a community health status assessment, and hospital systems are required to do a community health needs assessment. So that's one particular opportunity. There's also an asthma pediatric pilot focused around healthy housing and addressing asthma triggers in that population and bringing together the healthcare system, a community organization, Medicaid managed care, and working together to address and linking clinical and community interventions. Health eating, active living, bringing healthy foods to neighborhoods through Healthy Corner Store project. Also focusing on shared use agreements, opening up facilities and communities through shared use agreements that allow public to access those facilities, whether they be schools, churches, other facilities that are open in non-daytime hours for community to access those for greater physical activity. And a produce prescription program, which is a link between clinical and community efforts, where physicians provide produce prescriptions to hypertensive patients who are food insecure, and encourage them to fulfill those in their neighborhoods in farmers markets. Chronic disease management is both a clinical management focus as well as a chronic disease self-management focus. So we are actually working using the Stanford University Chronic Disease Self-Management Program, recruiting lay leaders and bringing community leaders into the community to lead those classes, doing culturally sensitive, linguistically appropriate training for physicians, and the implementation of a hypertension evidence-based best practice. So those were our priorities. Each of those subcommittees that Greg talked about, eliminating racism, are actively meeting, some every month, some less frequently, but are continuing. They have developed their work plans, are now full into the implementation phase. As we move forward, we have decided to really focus our attention on now, how do we sustain ourselves, how do we grow, how do we keep all this momentum going. And we've really reinvested ourselves in our approaches moving forward. And in essence, we've established these three pillars for ourselves as a partnership moving forward: collective impact, community engagement, and health and equity in all policies. So in essence, we've really started to dive deeper and explore the collective impact literature. It is for us a frame, not a roadmap per se. It's a frame that we use, and we actually organically came upon the use of collective impact by the nature of our process. But in essence, we follow these 5 conditions for collective impact around a shared agenda, common vision. We have a shared measurement and evaluation work group, mutually reinforcing activities, a lot of emphasis on transparent communications, and backbone support. So we've actually formalized our structure moving into action. As I mentioned earlier, it's been iterative. But we now have the planning group that we had is the HIP Cuyahoga consortium of well over 100 organizations. There's a 20-member steering committee, which in essence is a shared decision-making group. When decisions and plans need to be made, it's done collectively. And we've established a backbone infrastructure. So there's a backbone organization, and that's actually the Cuyahoga County Board of Health, and there's probably 4 or 5 staff deep that participate in managing the day-to-day operations, the convenings for this process. But we see the backbone infrastructure deeper than that. There is a lot of support being provided by our partners, which we value tremendously. So for us, in sustaining this work moving forward, we want to sustain all of the backbone infrastructure. So we want to sustain the backbone organization's role in managing, which is a huge administrative responsibility. We want to maintain the chairs of the standing work groups. We want to sustain the 2 co-chairs of our consortium. Greg is one of them. Dr. Heidi Gullett from the Case School of Medicine is the other. And there are actually 6 anchor organizations that commit time and energy to moving these 4 priorities forward. Community engagement, again, has been a pillar for us. We have accomplished much in the area of community engagement, but have a lot more to accomplish. But in essence, this is a visual of a group of community residents that have been engaged for a capacity and leadership training. The Case Western Reserve University Prevention and Research Center has been working very directly through the HEAL subcommittee in engaging community members. And this is actually the very first cohort and graduating class that is now continuing to partner with us. And this is the slogan that they created for their partnership. We've done community engagement workshops and held other community events and are committed to doing so in the future. Health and equity in all policies, Greg framed that really well for all of you. Our intent moving forward is to create a policy agenda that shapes policies for both upstream and downstream issues that impact our population's health. So framing our current work through the lens of policy and engaging decision makers in those efforts. We've held one key decision maker caucus to date, and we have 2 more planned over the course of 2 years. Our communication efforts have been very focused on framing, sort of understanding what is the problem, what's the value proposition, and what are we doing about it. And we've been privileged to engage communications consultants to support us in this effort, and has been instrumental in framing our strategies and our design. This is just an example of some of the ad campaigns that we've done in our target neighborhoods in the city of Cleveland. We are working on shared measurement and evaluation. We have established outcome measures and performance measures for each of our 4 priorities. This is a sample, but I will say where our greater challenge is to be able to consider how systems operate versus programs. We want to make systems and policy change and understand the effectiveness of our partnership. And again, we're looking to the Collective Impact Forum to support some of our work in reshaping our evaluation through this broader lens. And these are just a select key outcomes from our process. And just really want to recognize how important our resource and funding partners have been through our process. We have been able to secure funding over the course of the last 5 or 6 years that has gotten us to this point, and many of these really serve as partners and serve on our steering committee. More importantly is the in-kind support we've received, and we've probably leveraged over $750,000 in other grants to support the ongoing sustainability of our subcommittee's work. And we are now developing a resource and sustainability strategy moving forward. So it brings us just back to our core value, and this in essence is our roadmap moving forward.